All right, Chief. Thank you, Chief. Anyway, again, appreciate the opportunity here to kind of kickstart what we're calling the military health system track. And there, as many of you all were in the room this morning with Dr. Woodson, there's quite an ambitious program going on now with our military health system. And from a strategic perspective, I have never seen a time in my career where the leadership has us as what I call keenly focused on what we do and what we need to do in the future. And so we wanted to use an entire track here at the military at AMSIS to describe where we're going with the military healthcare system along Dr. Woodson's lines of effort. And so what you'll see, starting off with this, is each one of our briefings here in this military track supports the lines of effort that were described by Dr. Woodson this morning with our strategic initiatives and our strategic way ahead. And so again, it's an honor and a privilege, one, to be serving in uniform, but number two, it's an honor and a privilege to be serving as an initial director for the Defense Health Agency and working with, again, some incredible leaders that we have over there in the OSD side of the house with P&R and with Health Affairs. And so with that, I'd like to start off with kind of what I call a DHA 101. Now, how many of y'all know who Sun Tzu is? Yeah, you better be raising your hand if you're wearing a uniform. Okay? All right, so remember Sun Tzu initially said, know thy enemy, right? Which means, translate, who's in the audience? Now, allies, USA Today, you out there? No? Damn. Many of you folks, how many folks in here have actually had the opportunity sometime in this last 429 days? This is day 429 for the Defense Health Agency. We're 1 year, 2 months, and a couple of days old. And so how many folks in here in this room are actually in the DHA? Okay? Give yourselves a hand. Give yourselves a hand. Yeah. Happy birthday. Happy birthday. Happy birthday. All right. So anyway, this is a kind of where we've been, and then a progress report of where we are today, 429 days into this, all right? And then also kind of a peek into the future of where the Defense Health Agency is heading. So next slide, please. Chief, this is your part. There you go. All right. So I heard that. That's right. So anyway, folks that have been in my briefings before know that I always start with this slide. I always start with this slide because it reminds me why we go to work each day. All right? All right. The reason we are in the United States military, the reason we are in the military health system is our job, okay, is to support the men and women, the soldiers, sailors, airmen, Marine, Coast Guardsmen, coalition forces, and civilians that we ask to go into harm's way. And this picture is actually, it's symbolic of a lot of different things. But primarily, again, that happens to be a soldier there, but it could be, again, soldier, sailor, airman, Marine, Coast Guardsmen, civilian force, or coalition force that we ask to put boots on the ground in a remote location in southwest Afghanistan. But where it stands out in that picture is the load that soldier is carrying, okay? That's a pretty big rucksack. And so when you boil it down, what we do as medics, our job is to lighten the load, of that soldier, sailor, airman, Marine, whether it's mentally, whether it's physically, whether it's spiritually, or just good old-fashioned weight and cube. Our job is to lighten the load so that soldier, sailor, airman, Marine can perform wherever and whenever we ask them to do our nation's calling. And so what's important there also, all right, is to realize that everybody's on the team. So not just to deploy forward, but what's also important is that young clerk that answers the phone in the pediatric clinic. When that mom calls up and says, hey, my kid's sick, all right? And the answer ought to be, I'll squeeze you in, okay? Because what happens today, okay, it doesn't take long to get back to that soldier, sailor, airman, Marine, that their kid wasn't taken care of today, all right? And what's important is even that appointment clerk, that front desk clerk that's back at our MTF, whether you're at McConnell Air Force Base or Huachuca, okay, or whether you're in Mayport, all right, that in order for this soldier, sailor, and mermaid to keep their head in the fight, they got to make sure that their people are taken care of back home, their family and their loved ones. So I also love to use this picture to remind people, just because you're sitting back home doesn't mean you're in the fight, okay? And your job is to keep this person's head in the fight. Next slide, please. All right, here's our agenda. Next slide. Now, here's our lines of effort, okay? The Defense Health Agency is a main player. They are a major player in all these lines of effort. And you heard about these from Dr. Woodson this morning. And again, these are great, what I call inboxes. These are lanes, lines of effort, all right, where our military health system is making a difference. And if you look through there, I would argue they forgot to highlight numbers. We're a player in every single one of these. We are a player in every single one of these. And that's why it's such an honor and a privilege, again, to be on board right now as we move forward with an organization that ultimately, at the end of the day, looks at where is the joint first solution and where does it make sense. Next slide, please. Now, I love to show this slide, not because I'm in the Air Force, okay? Not because my dad was a B-17 pilot, all right, which he was, all right? But because when you look at this, Hap Arnold, all right, and for you folks out there that haven't studied about that separation way back when in 1947, but Hap Arnold, who was in the Army Air Corps, and really is the father of what we call strategic bombardment in military aviation. Before the war's almost over, he's already talking about the pilot in the cockpit may be obsolete, Now, it took about 40, 50 years, okay? And so I go back, and I grew up as a flight doc in a flight surgeon world, but guess what? 5 years ago, I guarantee you, I grew up in the fighter world, the fighter pilots were saying, ain't no way they're going to be firing a Hellfire missile off of no drone. How's that working out for them, huh? How's that working out for them? All right, so bottom line, adapt or perish. Adapt or perish. Next slide, please. Now, always key to set the stage. Why is what I call modernizing the governance and looking at better ways and more efficient ways to do our military health system, why is it important? Okay. Now, many of you all have been in Washington, D.C., but I don't know how many of you all have been in the room when the chairman turns to you and says, Doc, you're killing me. When I was a Joint Staff Surgeon, and I was Chairman Mullen, Doc, you're killing me. You're 10% of the top line. And I'm sure many of the folks here that have been on the air staff, okay, or on OTSG staff, okay, on the BUMED staff, have experienced the same thing with your service chiefs. So we have an obligation, okay, to the best we can to deliver a health care benefit that's most cost-effective, most efficient, but most important, and improves the quality of health care for our beneficiaries and our active duty force. Next slide, please. Now, many of you all have seen this slide before, but it's always fun to revisit it. This is what we call the famous solar system slide. All right? And this is where the money's being spent. Now, there's a lot of dark suits out there. All right? Just raise your hands. Okay? Hey, don't be afraid, all you dark suits here in the middle. Jeffries, raise your hand. Raise your hands. How many of y'all in TRICARE? Yeah, keep them up. Okay? You're in that big block on the left. You're in that big circle right there, okay? And I show that to you because our healthcare plan, a lot of our dollars go to our healthcare plan, and that's a good thing, all right? But when you look at the healthcare plan, the private sector care, and you look at the direct care system, which is our military treatment facilities, that's a large chunk of the money of our $50+ billion budget that we have, okay? Now, if you look on the right, okay, all those other circles are parts of the system that either help deliver that benefit, okay, or that drive policy and or organizational construct to deliver that benefit, both in the direct and also in the network care system. And so it's important to see where the money is spent. So we have to be making decisions, better decisions on the management activity. And when you look at that, just budget dust, okay, the overhead, all right? But really the changes, the policies, the way we deliver healthcare that can affect, again, the balance in the area what I call under the curve or inside that circle are key and important as we move forward. Next slide, please. Now, when we did this governance reform, and again, this is not the first time that we looked at how do we deliver healthcare, okay? How should we deliver healthcare, all right? There were 17 studies going back to 1948, okay? that looked at, is there a better way or a more effective or efficient way to deliver health care in the military healthcare system, right? And about half of them said maybe, had recommended maybe a more, what we call centralized command and control organization, like a joint medical command, okay? And about half of them said more what kind of what we call consolidated services or shared services, all right? Common services that all of the branches of the service use, okay, which is essentially a defense health agency-like entity, all right? And a couple of them said status quo, and we know how that worked out. Now, when we did this task force 3.5 years ago, okay, we spent about two weeks, if not more, asking ourselves a question. How do we keep from becoming the 18th study, okay, that goes on the shelf, okay, that the DepSecDef 5 years from now says, go out there and figure out a better way to deliver military health care, you know? So we spent a lot of time on how are we going to push the ball down the court. That's we only had 90 days. Okay, we turned into 180, by the way, but we only had 90 days. But that was a significant amount of time to spend on how do we ensure that we move the ball down the court, okay, and we don't become the 18th study that gets put on the shelf. Next slide, please. So here's how we got there, all right? So September 2011, the task force on MH governance delivered its recommendations for a new model for military health system governance, all right? And then the Secretary of Defense then took those recommendations, okay, and he concurred with two of the major muscle movements, and then gave us some vectors on the third. And then in November of 2012, we did a planning working group report that showed an implementation plan for the approved way ahead for a Defense Health Agency. And then on March of 2013 is what we call the 9 Commandments memo was delivered, said go forth, set it up, and make it happen. So that's the history behind where, now I could spend an hour or more just talking about how we arrived at a Defense Health Agency and a governance model that I'm going to describe to you today. And it was fascinating, but it was the most transparent, okay, that I have ever seen in delivering a way ahead for anything that I have done in my entire career. And when you look at the makeup of the task force, it was Army, Navy, and Air Force Medicine, okay, at the GO level. It was the comptroller, it was CAPE, okay, it was the line, it was the deputy J4, Marine Corps 1-star, who went straight to 3-star after he left the Joint Staff, and I'm convinced it's because of what he learned from the medics. And then we had senior official from OSD and services. So it wasn't just medics; it was the full spectrum. It was the folks. And so, you know, usually what happens, you end up planning something, you're building something, and then you say, hey, this is what we want to do. And then CAPE and the comptroller says after the fact, now you should have done it this way. That's why we brought him on board to help us build this organization so that we built it successfully and that we didn't run into any roadblocks down the road. But just team composition, number one. And then number two, what's important to know is because we had 180 days, we started out with 90, we ended up with 180 days. But folks say, hey, you know, how much buy-in for this? Well, our recommendations had to be approved not by one, but by 2 chairmen, not by one, but 2 DepSecDefs, not by 1 PNR, but 4. All right. So it was again a very large set of senior Department of Defense, both on the military line side. Okay, we did the tanks. Okay, we did the DMAGs, and on the OSD side, we ran it up through the chain, and we got vector checks along the way. So we built this thing, shared this thing with the concurrence both on the OSD side of the house and also on the military services side of the house. And I'm convinced that was one of the reasons we were successful in driving towards a solution that was acceptable to all parties involved, because that's not what happened in the previous studies. Next slide, please. Now, here's a reform we're undertaking. Again, this is all you know, I call it no-brainer, but you know, we've always said, hey, we need a more globally integrated, we need a system, you know, that's got standardized clinical and business processes, all right? And as Dr. Woodson says, hey, we need to shape the military health system so they're better, stronger, and are more relevant for the 21st century. And then I would argue back that the Defense Health Agency, okay, one of its primary goals is if you want to be relevant, okay, in the 21st century, okay, you got to be viable, okay? And the Defense Health Agency, when you think about it, the foundation is it's how do we become more viable, more efficient, more effective, more economical, and at the end of the day, we have a higher quality of care, and that's what the Defense Health Agency was created to do. Next slide, please. Here's a mission and vision, but I always like to skip that part. I'm a simple flight doc. I just go straight to the bottom of the slide, okay? Our job in the Defense Health Agency is to enable, okay, we are supporting, is to enable the service surgeons generals, okay, to provide to their service chiefs and the combatant commanders, okay, a medically ready force and a ready medical force. We are supporting, the services are supported, and that is key in understanding that relationship. Next slide, please. Now, everybody loves, especially you on the right side, you're on the left, but my right side, you love this chart because you can't see jack, okay? But it's your standard org chart. This is how we do business, did business, okay, prior to 429 days ago, okay? All right. And that's the service surgeon generals, and basically, what happened was, every service put forth a budget, and then we collaborated, we coordinated out there the best we could, but at the end of the day, you executed your budget, pretty much along service lines. And again, that has worked well for us for years. Now, when we made the decision to do a Defense Health Agency, next slide, okay, what happened was as we were creating, I talked about transparency. What was happening is we built this thing, okay? We didn't build this in a closet, okay? We built this with the services. And so when we looked at the 10 shared services, which are the foundations of where is a joint first solution probably the best way to go in many of the areas, okay? It's the services that help build the construct for those shared services that then contributed to the organization of the Defense Health Agency. I'm going to say that again, okay? It was the services that helped build this organization. Now, as we did that, and these groups that did business process and business re-engineering along a very, 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 what I will call templated manner, reproducible manner, along all those business product lines, okay? We ran those by the deputies, okay? And before we pushed it up to the service surgeon generals and Dr. Woodson. But what was happening was, and that's why it's important on the left-hand side, you say, well, what's the MPOG, the MOG, and the MBOG? This is important, okay? That construct on the left was created and evolved as we built the DHA and looked at validating and getting acceptance to where we were going to go. So what happened was the ops guys, the 3s and the 5s were saying, hey, you're starting to talk about the stuff that we do, okay? And I use the word, they said, we better tribe up, okay? So they got together and said, hey, we want to run some of this stuff through the 3 and the 5 group, okay? And then what was happening is then we start talking about personnel and changes, what's in and out of the DHA, and the ones were going, hey, that's our stuff. We better tribe up, okay? And then what happened was, and now the money guys, you can imagine what the money guys were thinking. Centralized pharmacy checkbook? What? Common cost accounting? What? We better tribe up. So they got together, and if you look at that, it's beautiful in the sense that what we created was almost like a pseudo-medical joint staff. Remember, it's unity of effort, not unity of command. The joint staff is unity of effort, okay? And so now you've got, the DHA, okay, personnel guys, and then the Army, Navy, and Air Force working together in these groups, just like we do in the joint staff. And then you move it up, through the DMAGs and up to the tank, and then, so it's just like the joint, in many ways, a lot like the unity of effort that you see on the joint staff. And that governance model there is what I'm convinced is one of the key to our successes. We change the way we govern and make decisions. We make decisions. No, it's not by committee. We make decisions, okay? We make decisions, and then we move on. Before it was committees, then you go back and sell it to your services. And if the services didn't prioritize it, not because they didn't want to do it, but if they didn't prioritize it, then the veto counted. Now what happens is the veto is noted, okay? Because the governance makes the decisions, and we move forward. Next slide. Then you have the Defense Health Agency in the middle, supporting, okay? The Defense Health Agency supports the services. What's key on here is that dotted line that you see from the chairman. We're a combat support agency. So we are answerable to the chairman. We are answerable to the chairman to ensure that we provide medically ready and ready medical forces support to the combatant commanders. That's key, okay? So the chairman can reach down and put his finger in this agency's chest and say, you're not supporting my combatant commanders, or vice versa. And we can go back and say, hey, we don't think the services are playing, and this is the same relationship you see with DLA, Defense Logistics Agency, DISA, Defense Information Systems Agency. So we're all combating kind of what we call CSAs. And so it's key that we have that relationship, and that's important. Next slide. And then you put it all together. Next slide. Now, here's the bluff, okay? As a combat support agency, we support the combatant commands, all right? DHA, Defense Health Agency, is to the medics, okay? When I talk to the line, they go, Doc, what's this DHA? I say, here, it's real simple. DHA, Defense Health Agency, is to the medics as DLA, Defense Logistics Agency, is to the FOR world, or the logistics community, okay? Or DISA, Defense Information Systems Agency, is to the SIX, or the COM world, okay? And when I say that, I just had a chance to talk to a couple of the combatant command vice chiefs, and when I said that, they said, you're right, I couldn't go to war without DLA today. I couldn't go to war without DISA today. And I said, you know, someday you're not going to be able to go to war without DHA. But again, it's going to drive, again, a more common base joint force solution where it makes sense. Next slide, please. Okay, this is another slide on the right side of the room. You could care less about this slide, but let me tell you what. This shows our organization, okay? All right, you guys can get a copy of the slide. Just drop me an email. I'll get it to you. Actually, Kane, where are you? You know, Captain Commander Kane, there you go. This young lady right here. Okay, but anyway, we have 5 directorates. We actually have 6, but we have five what I call execution directorates, okay? And we have the healthcare operations, all right? We have research and development. We have health information and technology. We have education and training, and we have business support. And those 10 shared services, which I'll show you, are nested inside those directorates, all right? And on the far right, you see the National Capital Region Directorate, okay? And that's Walter Reed, and it's Fort Belvoir. And just because of the way their Manning document was written, they had to be hung on somebody, okay? And the decision was made to hang them on the Defense Health Agency. So that's how they ended up in the Defense Health Agency. Next slide, please. And if you don't think we're serious, look at what is committed to that. Now, Defense Health Agency is a zero-sum game. Zero-sum game, okay? All right, anybody that's in the Defense Health Agency comes from the services. So that interdependence is key. Those 3 general officers that you see up there came from the services. No new general officer or SCS authorizations, okay? So the Defense Health Agency is, in fact, again, built from and by, okay, and is part of the services and our ability to give back what they need to, again, ensure that they have medically ready and ready medical forces for their service chiefs and the combatant commanders. So you got 2-star General, Major General Thomas in Healthcare Ops. You got a 2-star Admiral there, Rear Admiral Dahl for R&D. You got an SCS, Mr. Dave Bone, who came from the FAA, where he did their health information and technology transformation and consolidation. Okay, you got Brigadier General Bob Miller, who just came on board, running our education and training. And then you've got Mr. Joe Marshall came over from the Navy, who's running our business support. And then you've got, as many of you all know, that are in the local area, Rear Admiral Bono leading our National Capital Region there. Next slide. We are a global operation. Next slide. All right, and here's our 10 shared services. Again, we could spend an hour on each one of these, talking about the business process and the product lines, and then again, the re-engineering that we did to arrive at the cost savings that we said we are going to deliver. We will deliver. We have to deliver, because they already took the money. So anyway, so next slide, please. And this is what I'm talking about, okay? So we committed to $3.4 billion savings over the FIDEP, 15 through 19, all right? All right, that's a done deal. Anybody in the programming world knows they took it, you know that's why we didn't put 6 on the table. So anyway, but that's key. Now, what they also said was, don't commit to anything in the first year, which is 14, okay? Because they'll take that too, all right? And then you may start from bottom. But guess what happened? Next slide. We saved just in the first year $248 million, okay? All right? And that was just working together, just looking at consolidation, just looking at processes. And guess what? I had 3 of the directors come to me 1 October last year. What was happening? Sequestration, 25% of our workforce was laid off, all right? What a time to stand up an organization. I couldn't hire, I couldn't fire, and there was no money. And so, but it's the best thing that ever happened to us. Because if you want to act lean, all right, then you start out lean, all right? And so we had to have the discipline right from the start. So they came and say, I need some money for capital investment. I said, it ain't going to happen. There's no money. They came from their service. Well, my service always gave me money. It ain't going to happen, okay? Go find it. Well, they found it. They found it. So it's, again, I look back at it. Didn't sound good at the time, but the best thing ever happened to us was to start out in lean times, because you know what? You come together, you make it happen, you do it. Next slide. Now, in 14, here's kind of where we are. We put all shared services are in. Okay, they're all what we call IOC as of 30 September. All our senior leaders are permanent. They're not acting, okay? They're leading. They're leading by example, as I just talked to you about. And then we have our multi-service markets are functioning, and the business plan's approved, okay? And again, I've got Admiral Dalton coming after me, who's going to talk about the multi-service markets, which is another part of this MHS governance reform that was part of the SecDef's directive. Next slide, please. So here in 2015, we're going to continue to focus on increasing synchronization, looking at reducing variation. I mean, we could spend hours just talking about how that's happening in each one of our product lines. Now, there's a lot of things that we're looking at. Okay, we're going to go back, revisit our 10 shared services. Are we meeting our goals? Did we get it about right? What are some of the new initiatives? But we're also starting to tee up what we call future shared services, but not necessarily shared service, but future opportunities for standardization. In other words, looking at, hey, we ought to probably have an enterprise telehealth, operation run by the services, but we ought to be running off the same platform. We ought to have standardized education and training simulation, right? We ought to. One, we get a better deal because we all, again, can buy off the same vendor, and that's what your logistics director is going to do. Is going to get us the best price through DLA. All right, but then we're also going to be able to again start that interoperability, that jointness from the beginning, because we're going to all be starting from the same. And then the other thing we're looking at is where does it make sense for the centers of excellence to be? Okay, right now they're benevolently hosted, okay, by the services, but they're MHS centers of excellence. So we need to look at how do we ensure that they get their products to market, okay? And we can do that through our R&D community. We can do that through our education and training director. We can do that through our healthcare ops. So there's a lot of opportunity in the future. Next slide, please. Now, okay, I've already run out of time, but again, Admiral Dalton's going to talk about this, but this is key in the execution of where we're going. Next slide. Next slide. Next slide. Next slide. Next slide. Dalton, you're good. Hey, back up. Back up. Last slide. You're killing me. Oh, I can do it here, can I? Let me see here. No, step away. Hey, if I just touch my finger on this thing, will it come up? No. Oh, that's the FAA can do that. That's right. So anyway, our last slide. There, let's go. I love to show this last slide, and I end a lot of my briefings with this because number 29 is coming up. Coming up. There we go. I'm going to help you out here. Okay, so I love to show this slide because that first slide was talking about the quantity of life. In other words, saving soldiers, sailors, airmen, and Marines' lives, okay? Now, but that's the quantity of life, okay? But what's just as important and sometimes more important is the quality of life. It's the quality of life, all right? And that's for us to ensure that, again, that's why I come to work each day. You take care of that soldier in the field, okay? You get that severely injured soldier. We get them back. We're saving their lives like we've never done before. But more importantly, again, so they can walk down the hall with their husband and wife, their sons and daughters, their mothers and fathers, okay, and live a productive life, okay? Again, so thank you again for the opportunity to give you, again, a quick 25-minute run through the Defense Health Agency. And I'm going to introduce, where's Admiral Dalton? Come on up here, Admiral Dalton. All right. And what we'll do is we'll save the questions again at the end of the session for all of us. It's because what you're going to see is we're going to bring a lot of this together here as we continue to build it.